Good afternoon, everybody, and welcome. My name is Garrett Schmidt, and I am the managing editor for VBC Exhibit Hall. And I would like to welcome you all to today's live discussion webinar by PointRight, which is a net health company called Social Determinants of Health and the Risk of Poor Outcomes, to adjust or not to adjust. And this is a very exciting topic. We've had a huge amount of interest. This is one of our highest registered webinars we've ever done. And so welcome, we're glad you're here. So we'll jump right into it. A couple items of note before we get started. Everyone has joined today in listen only mode, so you don't need to worry about muting your mic. That's been done for you. Also, the webinar is being recorded. So what's going to happen is after we're done, I'm going to send everyone, probably later on this afternoon, this evening at the latest, I'll send you a link to the recording, and there will also be a place where you can download the slides. So even if you have to drop off early or you're not able to make the full presentation, I'm going to go ahead and send that to you then. And then finally, we want to hear from you during the presentation. So we have a Q&A session at the end that we're going to be able to take your questions, and definitely would love to hear from you at that time. So please ask your questions in the, you have a control module that has a questions panel on it. So not the chat, but the questions. So go ahead and ask your question there at any time. You don't have to wait till the Q&A in order to do that. And then we're going to get to as many of those as we possibly can today. Again, it's a hot topic, very highly attended, so we're going to get to as many as we can. But if we don't get to yours, we will answer via email afterwards. So someone will get in touch with you to answer your questions. So please ask it by all means. Finally, without further ado, I want to briefly introduce our speakers today. Ms. Janine Savage, who is the Vice President of Product Management for Analytics and Post-Acute with NetHealth. And then also Dr. Daniel Deutscher, who is a Senior Research Scientist also with NetHealth. So without further ado, I believe Ms. Janine Savage is going to open us up. So welcome, guys.
Thanks so much, Garrett. We're really thrilled to be with you today talking about this extremely important and timely topic. So today we'll discuss the definition of social determinants of health, why they matter, and some important considerations around using them in risk adjustment. So without further ado, based on the most recent CMS data, US healthcare spending has reached an all-time high, $4.1 trillion, or $12,530 per person, and that's 19.7% share of the nation's gross domestic product. Yet, despite this spending, health outcomes in the United States in some key areas are among the worst in the developed world. Life expectancy has decreased for the second year in a row. Maternal mortality is increasing with rates higher than most developed countries. Obesity rates are climbing, and the proportion of Americans who self-report fair to poor health is climbing, and it's grown steadily over the past 15 years. So we ask the question, why is that? Well, it's because medical care is estimated to account for only 10 to 20% of health outcomes, where 80 to 90% is actually attributed to social determinants of health. And those are the health-related behaviors and the socioeconomic and environmental factors that impact health outcomes. Genetics is an interesting one and is somewhat controversial in terms of social determinants of health, because genetics largely can't be impacted and are not social factors, but also account for a big percentage of health outcomes. Social determinants of health are defined as the conditions in which people are born, grow, live, work, and age. And that's a long-standing World Health Organization definition that is used by all of the leading thought leaders around social determinants of health. And these include economic stability factors, environmental factors such as neighborhood and physical environment, things like housing and transportation. They even include things like the zip code where someone lives. Educational factors are impactful, as well as food-related factors. In community and social context, how well supported an individual is within their community and how engaged that community is, the stress under which that individual lives. And last but not least, the healthcare system itself, access to care and quality of that care. These are all of the factors that impact health outcomes. And we know that there are significant barriers to addressing some of these factors. We have a very complex structure of healthcare delivery in this country. It's comprised of private, federal, and state programs and services. So that results in some barriers related to consumer experience. It can be complex for individuals to access care. There can be objectives that are misaligned and actually provide disincentives to use certain programs. And the requirements to maintain and use benefits can be complex and can vary widely. There are administrative barriers as well. This includes burdensome regulations and statutes. In some cases, we know there are duplicative and complex reporting requirements in order to participate in programs. And we lack a comprehensive central data system for eligibility and tracking and other important key factors about individuals. We also know that there are some data-related challenges and some very important questions to be answered still around social determinants of health. It can be difficult to collect data on social determinants of health from providers because in all cases, they are not collecting that data. It can be difficult to connect the data from community-based organizations to providers that are actually providing healthcare. And we really have a lack of success metrics to answer some key questions. The first one being, which SDOH are most impactful on health outcomes? And more importantly, probably, what can we do about that? And yet, despite all of these challenges, we know that payers, in particular, are using a variety of strategies to try to address social determinants of health and their impact on health outcomes. And this graph illustrates, or this chart illustrates some strategies that Medicaid MCOs are using to connect their members to social services. You can see that a majority of them are using some sort of strategy. But how do you know as a payer that you're actually spending your resources in the best way? And this is because the outcomes data is somewhat limited and we don't even understand the connections in many cases. That can be a very big challenge for payers. We also know that the initiatives to promote health and health equity are all around us in a very real way. Back in October of 2021, the CMS Innovation Center refreshed their strategy with a huge focus on advancing health equity. And their aim is to embed health equity considerations into every aspect of the Innovation Center models and to increase a focus on the underserved populations and their health outcomes. Not long after that, we learned that the direct contracting model for ACOs would be replaced by the ACO REACH model. And the ACO REACH model has a huge focus on developing and implementing health equity plans. That's a requirement of the model participants. And this is intended to identify underserved communities, to implement initiatives to reduce health disparities within those beneficiary populations. NACOS, which is the organization for ACOs, the membership organization, has signed on to an initiative that is being supported by Aligning for Health. Aligning for Health is a membership organization that brings together experts in health and health equity, addressing issues that have a common purpose. Integrated, coordinated care programs to improve health outcomes. And Aligning for Health is one of the supporters of the Social Determinants Accelerator Act of 2021, which is pending legislation. and would for the first time implement some standards for collecting social determinants of health data and how to start using that data. So this is a very important initiative to get better alignment across healthcare providers, payers, and patients, and advocacy organizations in order to start in a very coordinated way looking at social determinants of health and their health impact. And we also know that CMS is increasingly requiring health equity and social determinants of health to be considered in value-based payment programs. We work with a number of these types of programs at the state Medicaid level, and we know in working with state Medicaid agencies that the approvals of these programs is becoming increasingly dependent on incorporating these types of factors. So we're going to now kind of switch over. Daniel's going to discuss some important considerations related to risk adjustment of quality measures, the types of quality measures, that might be included in these types of value-based payment programs, in fact. Daniel?
Thanks, Janine, for this great introduction. Obviously, the topic of social determinants of health has been here for a long time. It's a hot topic. Data on social determinants of health are getting more and more important. And it turns out that this topic is actually pretty complex. And I'm going to continue this discussion towards the question of adjusting or not adjusting for those social risk factors when we create risk adjustment models that serve the measure of quality or payment systems. But before we jump into the actual discussion on adjusting or not adjusting, we need to have a discussion on can we do better? And in many ways, what you see on the slide here is really the message that I'm trying to send out. Because risk adjustment in this case, in many ways, it could be regarded as the last resort. So if we can't do better, let's do better. If we cannot do better, let's adjust for the risk. So we'll discuss this a little bit more in detail. On this slide, what we see similar to what Janine just showed us, and actually you see the title of this paper from about 15 years ago. So again, this topic is not new. We can do better. And so why can we do better? We see the 10% of proportional contribution to, in this case, premature death coming from healthcare. Only 10%, Janine showed that from another source just now. In some ways, this could be a little bit discouraging because we're spending so much money and effort in improving healthcare, and it accounts only for 10% of a patient outcome. But if we think of it a little bit differently, it's actually also encouraging because we look at all of those other factors, and let's put genetics aside for a minute. So we have 15% here on social circumstances, 5% for environmental exposure and behavioral patterns, 40%. So that's a lot, and that also offers us opportunities to do better. So again, we have to make that decision. Can we do better? If not, we should probably adjust in our models for those social risks. Another source that we can see on the next slide, from a few years forward, we're jumping here to 2016, but we see pretty much the same. This is a different model coming from other pieces of data and studies, but you can see here in the red box again, the quality of care within clinical care, we see the 10% again, and all of those other factors that we can choose to look at them as opportunities to improve patient outcomes, not only through the quality of care. Another study that came in just a few years ago on the next slide is from 2019. And this is a very interesting study. This is a study by Kaplan and Milstein, and I'll mention Professor Kaplan again in a minute. What they asked is, are those 10% really dependent on the method of estimating those percentages? And they compare different estimation methods, 4 estimation methods. But as you can see under medical care in this table, they came more or less to the same conclusion. You see the range here between 5 and 17% of the variance in the patient outcomes attributed to medical care. So overall, this really accumulates to very strong evidence. On the next slide, we'll see some data from the OECD. The OECD has the advantage of being able to compare data between many different countries, all of the OECD countries, and they have lots of data on healthcare expenditures. And they get again to 12%, as you can see here, of the variation in life expectancy explained by the variation in healthcare expenditures. A few weeks ago, about a month ago, I was fortunate to be able to participate in this virtual institute. And Professor Kaplan gave a wonderful keynote lecture. One of his slides, if you can switch to the next slide, please, reviews again what we've just seen in other studies. So we see again 10% for healthcare, and all of those other large percentages with the social behavioral accounting for 50%. But then Professor Kaplan goes ahead and shows some data on spending. Now, although we can account 10% for the actual healthcare, most of the spending are actually spent on those 10%. So if we want to make a difference, we need to shift more spending into other areas, addressing all of those other factors that can be outside of the direct healthcare system. So I think this is an important point when we think forward on what we want to do, and if we want to do better, we need to be able to address either within or outside of the direct healthcare all of those other factors. Now that we've gone through all of this, I think we can get a little bit deeper into the question of adjusting or not adjusting for those social risk factors. Within that same conference about a month ago, there was a great talk from Dr. Nerens. Dr. Nerens is one of the co-chairs of the scientific methods panel at NQF, which I'm also participating in. And he showed this study that looked at different characteristics of hospitals by penalties, by the risk of getting penalized within payment systems. And you can see here at the bottom that safety net hospitals have more than double the risk of being penalized when they participate in those programs. Now, the models here did some risk adjustment, but they adjusted for patient clinical factors, patient demographics, and not for social determinants of health. So when these social factors were not accounted for, they got penalized. And these are safety net hospitals. They're treating the most complex patients. So this is something we need to be well aware of. This is a risk. In this case, a risk of not adjusting for these factors. And we'll see the other side of the coin in a minute. But if we fall into this risk, actually this can become pretty catastrophic if we think of it. A safety net hospital being penalized, probably they need to work harder than others to get the same outcomes. If they can get the same outcomes, many times they cannot. It doesn't necessarily depend on them. And if that occurs, providers might not want to work in these hospitals. They might not want to treat very complex patients, which might not even be an option for them if they are in a safety net hospital. So this is, I think, an important point to note. The discussion, and some call it a debate, has been going on for quite a while. There were two, I think, very important reports that came out. The first one on the left here came out in 2014, and that comes from NQF. and the other one on the right a little bit later in 2020 from the HHS. Talking a little bit about what happened in NQF. Up to 2014, the NQF policy was really not allowing to risk adjust for social risk. So not only not recommended, but really not allowing. So measure developers submitting their measures to NQF, they were instructed not to account for social determinants of health. And you can imagine the reason. The main reason being, let's be careful. If we start adjusting, we can actually mask some low quality of care. So let's just not adjust. And then came out this report in 2014 that changed the policy, and we'll talk about that in a minute. If we go to the next slide, we'll see two diagrams that represent more or less what each report tells us. So let's start again from NQF. The diagram here on the left is, I like this diagram because it's simple. I think it's simple to understand, and it really sends the message that we're trying to send here. First of all, it's interesting to see that the diagram is symmetrical. Now, why am I saying that? I'm saying that because many times when people or scientists, researchers create those risk adjustment models, and also clinical expectations are more focused on the patient clinical factors and much less on socio-demographic factors. Here we see they're symmetrical. One is not more important than the other. But the main point of this diagram is to try and understand the causal pathway of the association between those patient factors, either clinical or socio-demographic, and outcomes. And we see two main pathways, two for the clinical and two for the social. The first pathway is represented by the line A on the top or E at the bottom. Those lines tell us that there's a direct association between those patient factors and the outcome. And this line does not go through the healthcare unit or the treatment process. Basically, what this tells us is that there's probably not much we can do about that association. These are predispositions that patients might come in with when they come through the door into the clinic, and such that we cannot modify, unmodifiable factors. Those are probably the ones that we need to consider adjusting for. But then the other lines, B and D, are factors that actually do go, the pathway does go through the treatment processes. And that suggests that we may be able to do something about that. We may be able to do better. These are the types of factors that we need to be very careful before deciding to adjust for them in a risk adjustment model. The big challenge is really to be able to understand those associations, and we'll discuss this again in a minute. The diagram on the right is, the idea of the report is really similar. Maybe the default is different. Here, the first step is to measure. The second one is really to set high, fair quality standards for all beneficiaries. So the big emphasis here is on doing it better for everyone. Let's put a lot of effort in doing better for everyone. And only as a last resort, adjusting the outcomes or the payment or whatever the system works on or is based on to beneficiaries with social risk. So maybe the main difference between those two perspectives or those two paradigms are the default. The default at NQF becomes, let's adjust unless we can identify a pathway that goes through treatment. And the HHS says something similar but slightly different. Let's not adjust, try to do better, and only if we cannot do better, let's go ahead and think of some adjustment. There are several common reasons that are provided from measure developers that submit their measures to NQF. And we can see those main reasons on the next slide, and I'll review those very quickly. The first one I've mentioned before, we don't want to mask low quality of care. We might do that if we adjust for social determinants of health, so we're not going to do that. Okay. The second one is more of a technical or statistical one, and it has to do with the added contribution of those additional factors to the predictive power of our model. Now that's a tricky one. And why is it a tricky one? Because it also has to do with how the method is handled. So for example, typically what's done when we create a predictive model, we start from demographics, we add those into the model, and then we add some clinical factors, and we get to a specific predictive power, like a C statistic or an R square, or depending on the model we use. And only then we have some social determinants of health data, we add those. When we do that, we might in fact see that there's limited added contribution to the predictive power. But what's tricky about this is that if you were to do that the other way around, let's say we started with social determinants of health and only then added demographics, and at the end adding the clinical factors, we might reach the same conclusion, limited added contribution, but for clinical care factors instead of social determinants of health, which would actually change our model. So I'm just mentioning this because I've seen this many times before, and we need to be very careful about the steps and the order of the steps and how we do our modeling. The third point is similar. It's a limited impact of provider ranking when we add additional factors, in this case, social factors. So we rank our providers using a model that adjusts for patient characteristics, demographics, and clinical, and we look at their ranks. And then we add the social determinants of health, whatever we have in our data, and the ranking doesn't change that much. So again, this opens up a discussion, how much is not much and how much is enough to make a difference. This is an issue that needs to be vetted very carefully. The last piece, Janine mentioned it before, just lack of data. We'd like to test for it. We'd like to assess it. We might even like to adjust for social determinants. We just don't have the data, so we can't do it. Regarding the data, on the next slide, we'll see an example for one important piece of data that if we have, might be very interesting to look at, and that's education. What this study from 2015 shows is something pretty remarkable. It looks at the risk for all-cause mortality, and it looks at this risk by the level of education. The bars in black represent the highest level of education, in this case, college grad or more, and all of the other levels are compared to this level. On the left, the crude model, and I realize this, the fonts here are pretty small, you might not be able to see that, but anyways, the one on the left shows a pretty impressive association, large differences. Those with the lowest level of education have basically 3 times more the risk for all-cause mortality compared to those with the highest level of education. What happens here is that each time we go to the right, we add more factors to this model. So when we add demographic, we still see this association a little bit weaker. And then we add income and we add other risk factors. And at the end, we even add behavioral factors. What's interesting to see is that association between education and the risk of all-cause mortality never goes away. It's still there, even after adding all of those factors. So this is just an example of a pretty strong variable. Other variables that are known to be pretty strong are, for example, dual eligibility. There's plenty of literature on that. So if that's something you can get your hands on, that's a good one to test. Janine mentioned area type of data, like area of deprivation indices, basically linked to zip codes, either 5 or 9-digit zip codes. So maybe we could even consider a separate session that would only discuss the issue of how do we get, what data do we need and how do we get to it. Next, I'll just mention a paper that was published a year ago, and as you can see, I'm I was part here of this group, so I'm not going to be very objective here. But I think this paper promotes the discussion. It doesn't provide a clear answer, but it promotes a discussion. And on the next slide, we'll see some basic assumptions that were made regarding the association between health care outcome and many different factors. So basically, those outcomes are not directly or do not directly measure quality of care because of all of those other factors. They may reflect quality, the outcomes, but not only quality, other things as well, which means that a good outcome does not assert high quality of care. And the end, the last assumption here is really that outcome measures should be adjusted for factors that affect outcomes but are not related to quality of care. So to give an example, we have three different scenarios on the next slide. The first one discusses a scenario of differences between providers. The second one discusses differences within providers, and then there's a third scenario. The between providers scenario tells us a story about some providers that have disproportionate, meaning large in this case, number of socially disadvantaged patients. And they actually provide lower quality of care to all of these patients compared to other providers that have less of these patients that are socially disadvantaged. And for those other patients, they provide better care. So that's a between provider difference. Differences could also occur within a provider, meaning that maybe some patients, especially those that are disadvantaged, get lower quality of care compared to other patients within the same provider. These two scenarios illustrate a case or two cases where the pathway actually goes through the quality of care. And these are the cases where we need to be very careful before we make a decision to adjust. We should try to see if there's something we can do to improve quality of care before adjusting. And then the last scenario is the opposite. Social and clinical risk factors have a similar confounding effect on outcomes, and the causal pathway to outcomes does not involve quality of care. That would be the case where we would or we should consider adjusting for those factors. And to wrap this up, I'm going to give an example also from a study that I was involved with already 12 years ago. And this was part of my postdoc work. What we did here is that we looked at data for patients post-stroke, and we compared disparities in motor function outcomes between Blacks and Whites. We had lots of data. As you can see here, we had patient characteristics, non-therapy ancillaries, and we also had therapy activities and specific interventions within those activities. Now, just a word to clarify what the difference is between therapy activities and interventions within the context of the study. The difference is the granularity of the data. Activities were kind of broad, general, like for example, advanced gait. And the therapy interventions were the specific interventions done within those activities. So what does advanced gait mean? It could be balance training. It could be motor learning. It could be maybe postural awareness. So these were two levels of resolution, if you'd like, of those therapy activities. And that turned out to be pretty important. The result of this study was that we can see the results on okay, here we go. When we looked at severe stroke patients, the patients were separated into two groups. We modeled patients that had a severe stroke separately from those that had a moderate stroke for different reasons. For those with a severe stroke, after controlling for patient characteristics and the activities, so the more high-level data that we had, we did see some evidence of Black race being significantly associated with lower outcomes. But then when we also accounted for the interventions within those activities, so more detailed data, that association went away. We didn't see it anymore. And we found that to be really interesting because we had proof in this case that the pathway of the association between the social determinants of health and the outcome actually did go through the actual care that was provided. This was evidence for us to make a decision not to adjust. If we were to create a risk adjustment model in such a case, especially within a quality payment program, we would then decide not to adjust, but instead do better, improve the care. So just to wrap this up, on this last slide that I will present here, I'm just going back to this diagram, which again, I like because it's simple. The challenge is to understand the pathways. Now, it does look very simple on this diagram. Actually, it's not that simple to identify those pathways. But as I think, as I try to clarify with this last example, the key for us to be able to identify the pathways is have good data. And not only data on social determinants of health, but we also need to have good, reliable, valid data on the treatments provided if we want to be able to identify those pathways. Okay, so with that, I'll hand it back to Janine. Thank you.
Thank you, Daniel. Some really, really, really interesting points and food for thought. So we kind of wanted to wrap this up before we go into the Q&A session with some considerations for you and your analytics provider and partner. And we believe that you really need to choose the right analytics partner by asking the right questions. Is data analytics their core competency? Are there solutions and use at scale with demonstrable outcomes? And how do they do the data science work? Do they have that deep domain knowledge in data science, but also a robust collaborative team? And as I think you've heard from Daniel's talk, it's really important to understand not only the data science, but some of the important clinical considerations and treatment considerations that could have an impact on the analytics work. The data sets that we use today are very highly complex, and that is in and of itself a core competency to understand how those data sets need to be utilized within these types of models. And as you've learned today, current knowledge and practices related to risk adjustment is absolutely key to know when to risk adjust, when not to risk adjust, and how to make that determination. And using an iterative data science methodology like the team data science process, the one that we use at NetHealth, is really the best way to execute. And of course, using modern data science approaches such as machine learning. So hopefully this will be helpful to you as you kind of vet out these things with your analytics partners. And with that, I will ask Garrett to come back and moderate any questions and answers.
Okay, great. Yeah, well, this is obviously, this is a wonderful presentation, and there's a lot here, and we do have some questions that have came in. So if you do have a question, go ahead and ask it now, and we'll get to, again, as many of these as we can. In no particular order here, the first question I wanted to give you guys is, what can ACOs actively do to influence SDOH's preventative through partnerships with external organizations like FHIR and EMS, HDM, and other such on the community ground, and how can it be incentivized?
That's a great question. You mentioned FHIR, the questioner mentioned FHIR, and you know, FHIR is extremely important in terms of data interoperability and getting us to the next step where once data is collected, we can actually start exchanging it and using it in a much more streamlined way than we have the ability to do today. So FHIR initiatives are extremely important. There are requirements for certain providers to become capable of FHIR data exchange and downstream vendor requirements as well. That's something we're working on in our organization actively. In terms of advocating for collecting SDOH data, I had mentioned one way, the Social Determinants Accelerator Act would really do exactly that. It would, for the first time, give us some standards for collecting data to be able to use that data. But I don't think that we should ignore the data that we have today. And I think sometimes we think that we need much more to even start this process. And most providers are collecting at least zip code and some other, and race and ethnicity and some other important demographic data that we can use today. For example, in many of our models, we use that type of demographic data. So we can't let perfect be the enemy of good, I guess would be my advice, and that we start using what we have today and work toward, a more ideal situation. And Daniel, I don't know if you have any additional thoughts on that question.
Maybe just one additional thought. One of the wonderful benefits of having lots of data, but not only large counts, also data from many different providers, is that it creates some variance in the data. And the variance can actually help us also identify champions. So using the data, we can identify specific providers that actually do a great job. And either we have the data to really understand what it is they do, but even if we don't, once we've identified those champions, with a combination of outcomes data, some social determinants of health, and all of the other characteristics, we can then go ahead and dig in and learn more what it is that they do that make them become champions. That can actually create a cycle. And it can create a cycle because we can then identify what pieces of data are important to collect that we don't collect, and add those. So I think this is a winning cycle. Lots of data, lots of variance in outcomes, variance in the way care is provided, offers those opportunities to identify those champions.
Very good. Okay, next question is, how do we get access to the data that is needed about social determinants of health and treatment in order to know whether to adjust or not?
So I think that depends on, who you are and the types of initiatives that you're working on. If you are a payer who is able to offer incentives based on performance, either through contractual arrangements, through a formal value-based payment program, that's the way to get to the data, as you design the way that program is going to be implemented, and you're going to evaluate quality performance. For example, that's what we do in some of the state-based programs that we work with. We consider those factors within the measures that are included in those value-based payment programs. We've also worked with payers who have contractual arrangements that have quality thresholds that are specified in those contracts that must be met in order for providers to either get payment or to get incentive or bonus payment. So the way to get the data is to, attach some sort of an incentive or a penalty to it. We're big proponents of considering both the carrot and the stick, because that's really the way to facilitate change in the best way.
Great. Next question, moving right along, and I apologize if any of these are repetitive, so let me know. But which health outcomes have the most evidence about impact on social determinants of health, or of social determinants of health?
Daniel, do you have thoughts on that?
Well, I don't think I have a very clear answer in terms of a quantitative answer. So which is the most? The fact, when we look at the literature, it's really all over the place, all over the health care system. So there's plenty of data, for example, on life expectancy outcomes, like the examples I've shown before. There's plenty of literature on the impact of social determinants of health on quality of life type of outcomes, cancer type of outcomes, functional status, heart disease, diabetes, obesity. I mean, it just goes on and on. So I don't know which of this is the most, but I think what's very impressive is to see how wide the impact is of social determinants of health on many, many different health outcomes.
Yeah, great. Next question. To what extent are the panelists concerned, this is you guys, concerned about existing data sets being used to explore social determinants of health and SDOH that may perpetuate implicit biases or be limited in their relevancy? Like an example, work highlighted by Zayad Obermeyer et al.
Daniel, you want to take that one?
Yeah, I would say that my main concern from looking at many different studies is maybe not so much the part about the social determinants of health data. That's improving over time. So I have a little bit less concerns over that. And there's, as I mentioned before, a lot of literature on probably the most important ones that are easy, relatively easy to get our hands on, like area deprivation type of indices related to zip codes, or payer data like dual eligibility. Those are relatively easy. But where I'm more worried is actually about the treatment data. That's where most of my worries are, because I think there's not enough attention given to that basic understanding of the pathway that I mentioned before. How does that pathway work? How really are those social determinants of health associated with the outcomes? And do they go through something that we can do better or not? That's something that we need to understand better. And if we don't, we could actually make some pretty serious errors in our choices of risk adjustment models. So that's mainly where my worry is currently. It's about the treatments. It's about understanding what exactly is being done to the patients.
I would offer another idea as well. I'm not as worried about implicit bias, because as models are developed in a robust way, we address implicit bias to the extent possible through those robust processes. But what I think is challenging in working with people is sometimes kind of the widely held beliefs when we're designing programs. And sometimes it's challenging to come up against some widely held beliefs. For example, some stakeholders might believe that there has to be risk adjustment because providers are, caring for a lot of socially disadvantaged patients. And it's sometimes challenging to refute that, and we do that by using the data and the information, presenting information like we did today. But I think that it's largely a challenge of people understanding more and getting more knowledge around these types of issues, and largely an educational process. So challenging those beliefs, I think, can be challenging sometimes.
Okay, great. I know there's a lot there, so we'll keep moving. Next question is, some ACOs operate in high social determinants of health areas already based on census data. What additional data would be required to be collected?
So I'm going to say it depends on what we're trying to measure and the types of quality measures we're considering and what might be impactful. But it goes back to, in the presentation, all those different categories of social determinants of health that could potentially be impactful. And as a practical matter, the data that we have available, what is being collected, what can be aggregated, and when it gets to model building and actually building the measures, what factors are determined to be impactful in those models. So it's hard to kind of give a general answer to that. It really depends on what the focus of your quality program is and what types of, generally it's some sort of utilization outcome that we're driving toward changing. So it depends on the measures that are being used to evaluate those outcomes.
I would maybe only add to that the granularity of census data is really important. So for example, if we go to indices that are based on just five-digit zip codes, they're pretty general. There aren't enough of these to be accurate enough on a patient level. And we really need to access more granular data that are specific to a very specific neighborhood or a street. And these data sets exist. If you log on, for example, to neighborhood atlas, I think that if you Google neighborhood atlas area deprivation index, you'll get to some great sources that get all the way to those 9 digits. And that adds much more accurate information. So I think there's a lot in census data, but we need to pay attention on the granularity of those data.
And we also look at, the provider location, the provider zip code. We tend to think always about the patient zip code, but we also can see sometimes interesting information based on the location of the providers. During the pandemic, this came out, was publicized about skilled nursing facilities who had a disproportionate number of deaths and related that to where those providers were actually located. So that's another aspect to consider.
Okay, great. Moving right along here, next question is, how has the pandemic changed the priorities and needs for identifying plus acting on the risks of social determinants of health?
I think we've heard more about this because of the pandemic, right? And there have been some very specific studies done looking at some of these factors as we've learned more information about what's unfolded during the pandemic. So I think it's spotlighted attention on this issue. Daniel, your thoughts on that?
No, I don't have a lot to add. I think in a crisis, in a period of some level of crisis, and this is what it was some level of crisis, the disparities that we typically see are just more extensive during those periods. And so that relates to what you just said, Janine. I mean, we've paid more attention, but it's the same problem. It's just more extensive during a period that's much more difficult to deal with. But I don't think it changes anything substantially in the issue. The issue was there before, it's going to be here after.
Okay, agreed. Next question is, please forgive me for the naivety, but just to be clear, when you say risk adjust using SDOH factors, are you referring to actually impacting RAF score? And if yes, then which factors are allowed to be used for that?
So we're not addressing specifically the RAF score. That's a well-established methodology. But how we potentially adjust specific quality measures that measure either process or outcomes or utilization around healthcare. So kind of in a more general sense, quality measurement, and whether or not we look at SDOH as adjustment factors to risk adjust those measures.
Okay.
I can just maybe add an example,
yeah,
just to make that clearer if it helps. So the example I gave before regarding race, the outcome was a functional status type of outcome. So when we create a quality measure that looks at functional status, and we adjust for some baseline characteristics that we regard as being unmodifiable by the provider, then comes along the question about race. So let's say we see lower functional outcomes for a specific type of race. Do we adjust for it or not? So, and then obviously there's no upfront answer to that question, yes or no. We have to look at the data, understand the pathways, and only then make a decision on whether to account for race or not in the context of that specific quality measure.
Yeah, great. And that actually might go along with this next question that came in. It says, the study that Dr. Deutscher cited from his postdoc reads to me as an illustration of racial disparities in care. I would be concerned with masking racial disparities. Can the panelists address this more explicitly?
I absolutely agree. And that's the conclusion that we reached. If we were to adjust for race, in that case, we would in fact mask for disparities in care. The point was to demonstrate that we used detailed data, not only on the outcome, on baseline patient characteristics, but also on care to identify that. That allowed us to identify that the disparity was in fact within the care provided. And I can provide more details. We basically found that more of the good stuff was provided to whites compared to blacks, and more of the not so good stuff, passive interventions, things like that, were provided more to blacks. So the disparity was in the care, and that's a case where we can do better. So we don't want to adjust, we want to do better.
Yeah, great. Totally. That's a very important point. So I'm glad you were able to expand on that. We are running out of time here. So I wanted to, lastly, as we are closing out here, thank you. And we do have some extra questions, and I'm sorry if we weren't able to get to yours. We will respond by email afterwards. So even if you have one last second here that you want to throw in, please do that, and we'll get back to you. But we are out of time, unfortunately. As we wrap up, I did want to encourage you to visit the booth, the virtual exhibit booth on vbcexhibithall.com for Net Health and PointRight. And if you go to vbcexhibithall.com, and you can find the booth there. There's a little picture. There was a picture on the slides there. He was jumping around. But there's places where you can interact with their team and download some more information and just kind of get a deeper dive into what they're doing in the value-based care area. And then lastly, if you have any questions for either of our speakers or would like to reach out to either of them or interact, feel free to, you can contact Lisa Ertner here, and she will put you in touch with the speakers. And also you can interact with the Net Health team there, or you can reach out to me if you would like, and I'm happy to put you in touch. So in the interest of everyone's time, thank you so much for joining us. We know there's a lot vying for your attention right now, so we appreciate you spending the afternoon with us. So have a wonderful rest of your weeks and stay safe and healthy. Thank you again for coming. Bye-bye.
Thank you.
Thank you.
Bye.